Welcome to the podcast, Dr. Lyster. So excited to have you here today. We are always up for an expert in perimenopause and menopause because so many of my listeners are in that stage or they know somebody in that stage. So it's lovely to have you here. We're going to deep dive into some of the symptoms, and of course we'll talk about weight gain because I know a lot of people struggle with that, and some how to get past some of those symptoms and look at it. I love how you look at it as like a positive time in life and something to look forward to. So
Exactly.
please tell us a little bit about your background and how you got to be so interested in this subject and in the area of women's health.
That is such a good question because my story definitely is related to it. When I was in medical school, I remember on my OBGYN rotation this one encounter with a patient who felt so much better just after talking about how she was feeling. Okay, I was a student, so I wasn't writing any prescriptions. I don't know if the resident I was following wrote for any hormones for her or anything like that. But that's what stood out in my mind is how much better she felt just from the interaction. So that was definitely an influence. Then I went into OBGYN, and then I went into menopause when I was only 43.
Oh, yeah, that was pretty
Oh,
early.
yeah. So my kids were little. That was pretty early. I did not know what to expect because my mom had had a hysterectomy in her 30s. And there I was. And by that time, I had really developed an interest in all things related to hormones and I just a lot of personal connection to my patients, I would say. And so there I was, and I knew that hormone replenishment was safe. I knew that a lot of the fears were misplaced. I already knew that from knowing the data behind the scenes. So then I just really took up the mantle of teaching, talking with women, which was always my favorite part of my job. And so as I narrowed down my focus, stopped delivering babies, stopped doing the major surgeries, what I ended up doing is what I do now full time, which is mostly talking with women. Men are about 10% of my practice, so 90% talking with women, and I just love it. I get to do my favorite part of my work as my full time, so it's really fun.
Yeah, the education piece is so important. And so many doctors in the conventional space just don't have the time to sit and educate like they would really like to. So when you go out on your own and you develop your own guidelines and parameters, you can do more of that. So I'm curious. So you went through menopause at 43, and I know the average age is 51. Do you think
Exactly.
there's anything in particular, any triggers that might trigger something early, or do you think it's just more of a personal thing and that's just what your body's going to do no matter what kind of lifestyle you live?
I think lifestyle definitely helps and influences. The issue which I think you're speaking to is can we control what's happening? And our female bodies, we learn to roll with things with our health. I think even more than the men do. They have
We
less
have to.
less fewer moving parts than we do.
Yeah.
So, but again, like I didn't know what to expect with my mom, but there's not a very strong genetic component.
Okay.
A lot of women, if a woman comes to me and says, my mom went through menopause when she was 35, and so did my four older sisters. Okay, fine. If it's that strong, then she may have that possibility, but it is not for sure. There's really no strict predictor. Then, of course, there's endocrine disruptors. A lot of people talking about that nowadays. And that's a really tough topic because it can be overwhelming if we don't want to just go live in a bubble.
Yes.
So it's really hard to say there was nothing dramatic that was different. I really think it was just early on the curve of the ages that women tend to go into menopause.
Yeah, yeah. I've heard the same thing. There's really no predictability to it. And
Yeah,
I'm
yeah,
48, well, I'll be 49 in a few months. So I know my hormones are on the decline just from some testing and a few symptoms that are starting. But I still, it's like this last month was 27 days. There's
yeah,
it's still pretty predictable. And it's one of those things
yeah.
that we say, it's like I would love to keep my hormones, but man, you're just ready to shut this off too. I'm like, my daughter's 21 and my kids are college and high school age. I'm like, I don't really need this any longer, but my body thinks it's healthy enough to
Right.
sustainable
Yeah.
apparently.
Shannon, you might end up being what I call above average because you're already so dialed into the healthy lifestyle choices and the looking at closely at the metabolism. When things are real, sometimes women come to me in their late 40s and things are a little topsy-turvy and their period might be getting irregular and further apart and they're looking forward to when it's going to go away completely,
Yeah.
and then we get things in balance and boom, their period comes back nice and regular,
Yeah.
like, yeah, well, okay.
Yeah, I thought it was on the way out, but no.
Yeah,
Yeah,
yeah.
you can't really just
So
turn it off like a switch.
yeah, hopefully without the other signs of any imbalance like the PMS or some women, if a woman comes to me and she says she's had an ablation, that means she was having really heavy periods. And that means that the analysis wasn't done to look at the underlying causes, what was causing was there estrogen dominance, what was happening. So yeah, lots going on. You're at an exciting time.
Yeah. I
I'm a
know, like
decade,
2
I'm a
more
decade
years.
ahead of you.
Our youngest is a junior in high school. It's like, wow, 2 years and we're like empty nesters. It's a very positive time of life. It's just different. There's just different shifts and different everything's just moving in a different direction than what I'm used to, but that's okay. Like I'm trying to embrace it as much as possible. So there are a lot of symptoms that go along with perimenopause and menopause. And my population, we really key in on blood sugar and metabolic health. And a lot of my listeners and followers are also keyed into cholesterol because as a part of metabolic health, that's what is typically tested. We look a lot at fasting insulin and fasting glucose. But I've seen even my own cholesterol panel start to, like, my cholesterol has risen a pretty substantial amount. And that's another reason why I'm like, okay, I know I'm getting into the thick of perimenopause because my cholesterol went up probably 40 to 50 point, like my total, my HDL also went up a pretty significant amount. But I know in my head, like what's kind of happening, but a lot of women would get that done and start to panic, be like, oh my gosh, my cholesterol took a huge jump. What's going on? I haven't changed my diet. I haven't changed my lifestyle. I'm doing all the foundational work. So what's the connection there? We'll talk about symptoms, but I do want to key in on that because I do have a lot of listeners who have like a jump in blood sugar, jump in fasting insulin, a jump in cholesterol, and they're freaking out about it. And most conventional doctors aren't very helpful because they'll just say, that's just what happens. Let's put you on cholesterol medication, which is about the
Yeah.
last thing that I would want for myself. So yeah, talk about those symptoms a little bit and what we can do about it.
I'm going to add your phrase, that's just what happens, because
Yeah.
I call it the J word, just. It's you're just getting older, you just have to accept it. So I'm going to add that one. It's just what happens. And then of course a cholesterol medication is a band-aid, right? That's what I call a band-aid medication. It's not looking at what's happening underneath. So it's very interesting, as you've covered before. The first hormone that starts to go down, starts to decline, is as early as our 30s, is progesterone. And then estrogen it can start to decline, but can also increase. It starts to get erratic, right? And we know that estrogen enhances the activity of insulin, and progesterone, like the name implies, progestation for pregnancy, can lead to some insulin resistance. All right, so it's no wonder that things get dysregulated. Okay. Loss of sleep from progesterone, from lack of progesterone. So progesterone calms the brain, helps with sleep, and sleep disruption and insulin resistance. Definitely something that you have addressed in your podcast. Very, very critical, super critical. When a woman comes to me and she's having sleep issues, that's usually where I start, right? In terms of symptom approach. Where I also start is with a really detailed panel of blood work. So looking at all those hormones, looking at vitamin levels, looking at basic organ, liver, kidney function, as well as thyroid, really detailed look at thyroid and adrenals. So thyroid and adrenals, they really partner up. They're the core of how we feel. And I heard something cute recently, which was men's hormones are like a barbershop quartet and women's hormones are like a 100-piece orchestra. And I thought that was
At least,
great.
yeah.
Yeah, right, at least. And I use the analogy of that hormone symphony, and the conductor is thyroid. So that's really, really, really important to all of this. Thyroid is really important to cholesterol metabolism. The thyroid activation of the inactive T4 thyroid hormone to the active T3 occurs to a great extent in the liver. It occurs in the muscle, it occurs other places, of course, and thyroid. But where it is happening in the liver, that's what's affecting those cholesterol changes. So I tell this to patients all the time. Most people out there who are on those cholesterol medications, what they actually have is something going on underneath with thyroid.
Oh, okay.
Mhm.
Interesting. Interesting.
Yeah.
So, do you see a lot of women struggling with high morning blood sugars as they progress through perimenopause and menopause? And what's happening there? Because I, yeah, I teach all about like getting insulin resistance reversed. And now we're starting to bring more of the circadian piece in because if the cortisol is dysregulated, the melatonin is usually dysregulated. And those master hormones are dysregulating insulin. And it's really, really tough to get insulin resistance resolved if you have the cortisol, the melatonin, and even the leptin out of balance. So we're starting to talk a lot about that, but I've seen me personally, and I've seen a lot of women my age who have done all of those foundational things and don't have insulin resistance, and they're still seeing the blood sugar creep in the morning. Is there anything in particular metabolically that you can link that to and, give us a few tips? Like I used to fast throughout the morning for years and I've stopped doing that and I've resolved
Beautiful.
cortisol issues
Yeah,
within a
that
couple
is
of
great.
months. And it was eating earlier, plus like being out for sunrise, doing lots of grounding, getting that cortisol trigger in the morning to, because mine was flatline to boost it. And I
Yeah.
haven't on a continuous glucose monitor, but I still am not like where I was for morning blood sugar. So I'm just like, what can I, if I'm missing a connection there somewhere?
Not only are you not missing a connection, but you've drawn attention to a couple of really important topics. One is that I had clinically observed for years that intermittent fasting for women doesn't work as well for certain goals as it does for men. For sure, it doesn't work as well for weight loss. And you just touched on the reason why. So, all of us human beings, we have what's called a cortisol awakening response in the morning when we wake up. That's normal. That's how we get to feeling like we woke up. And then it's supposed to have a nice gradual decline over the day. It's not supposed to crash in the afternoon. And it's supposed to drop down enough that we can unwind and go to sleep at night. Our female bodies experience that cortisol awakening response differently than a man's body. The increase in cortisol, that's what cortisol's there to do. It's to mobilize sugar into the system. And then, of course, you combine that with hormonal changes, and then you've got the body composition changes. I'm a decade ahead of you. I'm 59. And dealing with that in, after a lifetime of being active and exercising and whatnot, and seeing body fat move around is really slightly alarming. So I'm really a
Why can't we
student.
just push it where we want to?
Yes,
It goes to places we don't want it. Like, can I just push
that's
it
right.
into my chest area and leave it there? That would be good for me.
Yes. Well, unfortunately, I'm going to say unfortunately, we could also just say for better or worse. There's some plastic surgeons out there who are like, oh, I can do
Yeah,
that for you. Take it from one place, but it's like, oh, I don't know about that.
right.
So that's really, really critical. So that early morning, that fasting, especially when women go work out,
Yeah.
that compounds the problem.
Yep.
So I think that Dr. Stacy Sims is really an expert with all of this. She really advises elite female athletes on precisely the timing and what to eat and how much, etc. But some of the guidelines that I've arrived at based on her scientific work, I think is really helpful. So not only do we have that cortisol increase that our female bodies experience as a stressor, not the same as in men's bodies. And it has to, she talks about the receptors in the brain and the hunger regulation. There's like a whole science to
Yeah.
it. I like to look at the overall total picture. So that's important too, to what you're saying, Shanna, because if if a woman has the basic results, all right, so if she's feeling good, body composition is responding to her efforts, then we're good. As you said, the metabolic markers can change a little bit, but if it's not leading into prediabetes, then from a health standpoint, then she's doing good. So I like to always keep in mind the overall picture and the major goals
Mhm.
that a woman has. So obviously, we want to keep a lid, let's say. We don't want insulin resistance. We don't want the changes that come with that. All right. We don't want, and of course, we don't want to end up going into prediabetes or diabetes.
Yes, for sure. Yeah. And what's interesting with my labs that I've seen is my morning blood sugars were always beautiful until I went through some major stress and my adrenals just, and in perimenopause, your adrenals are asked to do more work, take over
Yes.
for the
Yes.
ovaries. And I think everything compounded. All of a sudden, I was having high morning blood sugars. I'm like, wait, I haven't eaten for 17, 18 hours. What is going on here? And I don't have high cortisol in the morning. I have low cortisol. Like what is the connection here? It was really tough to figure out. And it wasn't until recent until I took care of the adrenal issues
That's
that
right.
fasting insulin, like my fasting insulin was hanging out somewhere between 7 and 10. So pretty healthy, but all of a sudden it's 2.2. And it's like it's a much healthier, there's just a lot
Yeah.
more sensitivity there. Um,
Nice.
but I am like, I still need to put on a continuous glucose monitor because I don't think my morning blood sugars are quite where, but there again, there
Yeah.
are a lot of shifts going on, I think, for me. um,
Yeah, that's exact. You're exactly at that point. So the curve of estrogen at least is kind of going this way. We get into our 40s and then late 40s it goes up, down, up, down, up, down. I call that the stock market phase.
okay. Oh, that's a good term.
Because it looks to me like the up and down of the stock market. And then that's as the ovaries are heading into retirement. So it is bumpy. It
Mm,
is bumpy. I do like I'm wearing my glucose monitor now. I wear it from time to time just as a like couple of weeks of research
yep.
and see what happens. And so obviously, as you know and talk about, we're aiming for rolling hills. We just want to see what's spiking. At this point, I have a pretty good idea of what I need to do. And also, I've been raising my protein intake. That's also, of course, very helpful to carbohydrate processing, carbohydrate tolerance. A lot of women, with all of the diets that are out there, remove all carbs, or they try to at least. And that might be okay when we're in our 20s and 30s, But then in our 40s and 50s and better, I think that we have to reconsider that. We have to look at that differently because, again, that cortisol awakening response, which you now have, so yay, that putting fuel into our body, including protein, especially before we go work out, is really, really important. One more thing I wanted to say that you touched on, when we as women, we have stressors in our lives, at least for sure in the United States. My family's from Argentina. My parents were both born there. And Argentina and lots of Latin America very much focused on the nap. The nap is like a good
Yeah.
cultural thing, okay? But here, that's not what we do in the US. Here we muscle through, we power through, and the adrenals are what help us do that. And so when we don't do other things to help the adrenals recover, that's when we get into the cortisol dysregulation, and you've got that it's not doing that appropriate rise and gradual decline like you experienced.
Yes, and I'm glad you talked about the carbohydrate intake and the morning eating. It took a while for me to shift back to that. I was always one of these people who loved breakfast. Like I would wake up hungry, and then you hear, and then I discovered I had insulin resistance, so I went to more of a lower carb approach. I was never no carb, and I don't teach no carb. I teach low carb, and I do teach ketogenic for some people for a certain amount of time if they
Some,
cannot burn, yeah, if they cannot burn fat, just to
yeah,
do that for a while to get their metabolic machinery working again.
yeah,
But no, I've never believed in like we shouldn't eat any carbs or but I do think, like you said, high protein in the morning with some fat, sticking to lower carb in the morning for sure, just to stabilize the blood sugar, and then bring some little bit more carbohydrate in the middle amount of the middle time of the day when we're the most insulin sensitive seems to work well for a lot of
yeah,
women. And then, backing off again in the evening and having that a smaller meal. But yeah, and I think we can dysregulate sleep and thyroid very easily if we're not careful about integrating some carbohydrate. And more recently, I've gone to, like I always say, like look at your nutrition on a 1 to 10 scale and just try to move toward the 10 realistically, in
yeah,
a way that works
nice.
for you. But getting to that 10 would be like you're eating seasonal, local, organic. A lot of people are like, oh my gosh, like I just have to get some sugar out of my my diet
Right,
first,
right.
and I have to get
Yeah,
I have to get used to eating more protein. But there are a lot of very savvy women who listen to this podcast and have been doing all of these things, and they're just looking for fine tuning. So any little snippet they can pull out of this
yeah,
conversation is really helpful. Uh,
yeah.
so
Yeah, here's another interesting area that I was thinking about getting ready for our conversation, and that is what to do as we go into menopause. So there's some good data that indicates that replenishing the hormones sooner than later can be can have advantages. Okay. Now, as I always say, I'm not here to persuade women to use hormones, although I am I mean, I've always known the benefits of hormones. The risks that people are aware of related to hormones are mostly due to the wrong hormones.
yeah.
So the big Women's Health Initiative study, which is more than 20 years old now, but has influenced an entire generation of doctors, unfortunately, and women who've gone into menopause during these last couple of decades and left sort of high and dry and not feeling good and not sleeping well and all these other concerns. So it's really challenging. I mean, it's always challenging for our female bodies. There's a lot of, like we said, a lot of moving parts, a lot
Yeah.
of orchestration, pun intended, between all of the different hormones. But estrogen we know improves insulin sensitivity. And so if a woman is having symptoms of estrogen deficiency, lack of estrogen, which can be the hot flashes and night sweats. People usually know about those, but it can also be related to mood. It can be the irregular period before getting all the way into menopause, but definitely after going into menopause. That's usually really a low estrogen state, and estrogen really makes a difference.
Yeah.
It's so fascinating, the effect on the muscle and the liver, the direct impact of enhancing insulin sensitivity. And then, of course, we have to balance that with progesterone, which has the opposite effect. So it's very interesting, and it's important for women to be aware. So you're helping raise awareness, and our conversation kind of shedding more light on what's happening hormonally. I mentioned that when I was 43, I was writing my first book. I thought to myself, I should do my labs. And my FSH was 54. I was up in the menopause range. I was like, well, okay.
Yeah.
So that was happening at that point. And then I had about one hot flash, and I knew the benefits of estrogen, and I already knew that the data about the breast cancer risk was because of the progestin, not the estrogen. And I had an office, I was still doing gynecology at that time. And so I had a cupboard with samples, you open the cupboard, reach in. So I grab a patch, stick a patch on, and that was that.
Nice.
So my goal is that women feel good, not suffer, and be able to manage the not just manage the changes, but really get to where they can feel good.
Sure. Yeah. So let's talk more about hormone replenishment, because it's always a fascinating topic and you hear so many different opinions on it. But I would imagine, are you going off of symptoms plus testing? And I guess my question is, if somebody doesn't have symptoms and they're feeling well, they're not experiencing symptoms, but maybe their labs look wonky. Are you suggesting like maybe they start the replenishment earlier? So talk about the testing a little bit, what to look for. I mean, I know the tip of the iceberg about the
Yeah.
hormone replenishment and the testing and that, but it's so hard because there are so many different opinions out there about what's high and what's low for certain female sex hormones. And I mean, it's a Goldilocks effect for all the hormones. So um you don't want to start something if it's not necessary, but you want to feel good. So like, I guess I would be a good scenario here. Like, I don't have, like, I feel good. I have energy. I don't have hot flashes, but I know I'm starting to go down that road. Like, what would you say to someone like in my shoes, where
Yes.
know that the things are starting to happen, but I still feel good. Like, are you basing off
Yeah.
symptoms or testing more so?
Yeah, exactly. The answer is yes, definitely the holistic whole picture. So I do a really detailed panel of blood work with a urine test as well that's related to thyroid
Yep.
and in combination with symptoms. So I was smiling when you first were saying that because women who are feeling good usually don't make it all the way to my practice.
Yeah.
Okay, so we've said that. So we want that. So we want the panel of blood work. And of course, one of the things I fantasize about is wouldn't it be amazing if everybody got a baseline panel when they're 20 and then when they're 30 and then when they're 40 and then by the time she's having issues or symptoms, she's 50 or older, then we kind of know what's normal for her. So that we don't have that information yet. So one of the things that I was thinking of, and the other thing is that, again, you've made all these adjustments, the most important adjustments, which are the lifestyle adjustments. I always say I cannot out hormone
Yeah.
someone's lifestyle. Okay. So if her sleep hygiene is terrible, then I can give her some progesterone to help her calm down and sleep, but not if she's doing all the other things that we need to not do as part of the evening wind down and the bedtime routine. Okay, so there's all of that. Let's see, what else would I do? I really would want you to, at some point soon in the next year or two, get a baseline bone density.
Okay.
just to see. The U.S. Preventive Services Task Force recommends that women get a bone scan when they're 65. Well, I mean, that's crazy.
Yeah.
The, the
But
ship is long gone by
yes.
that point.
Yes.
Okay. So, of course, before I even do the blood work, I've done a really detailed history and what's happening with lots of areas, sexual function, uh, expression in your life, that type of thing, which of course you're already doing awesome with all of that. But those are the questions that we talk about. So we've got the labs, and then we want to interpret to optimal, not just barely squeezed into the range. Okay, so we see that a lot. Another message that I have for women in perimenopause is if you're having symptoms and you're just not sure if it could have a hormonal basis, what happens, unfortunately, is a lot of doctors say, well, you're still having your period, so therefore it can't be your hormones. And that's not true. So I do like to get that message out as well. Lots of things that happen that women are given band-aids for. Mood issues, they're given antidepressants. Sleep issues, they're given sleeping pills. Menstrual irregularity, they're given birth control pills. So sometimes you need a band-aid, but we don't want to not look at what's happening underneath. So you're already so way ahead of the game because of all of the detailed level that you're looking at things.
Sure. Okay. But bone density testing is definitely a good idea. And
Yeah, just the baseline. If it's
yeah,
good, you can go
yeah,
a while. You know,
yeah,
again, you have so many healthy habits in place, Shanna, that you really could end up being above average. Average age, as you said, age 51 is when most women go the 12 months and then considered to be in menopause. That's how I use the terminology. Menopause, post-menopause, I use them interchangeably. So that can be already in place, uh, but and you can feel good. But I really like to know the status of a woman's bones because we don't build as much bone as men do, bone mass, right, in the first place, which is one of the reasons that we're more prone to osteoporosis. And so I just really want to be sure, if it's on the low end, then that would be in favor of introducing really low dosing.
yeah.
I like to start everything really low and work up as needed.
Okay. So for the bone density, it's strength training, healthy eating, and then the hormone replenishment. Is
Exactly.
that
Absolutely. Yeah. We know estrogen is the best treatment. I don't like the bone drugs. The vast majority of them are what they do is they interfere with the reabsorption of the old dead bone. They don't help with laying down new, healthy, good, strong bone. So what happens is the imaging looks better, but the bones are not stronger.
Sure. Yeah, that makes sense. I've heard the same thing. I remember when I was a young dietitian, like just out of college, and we had like a bone density clinic, and all we taught was high calcium foods and taking Fosamax or Fosamax, however it's pronounced.
Right. Yeah, that's a bisphosphonate. There's a bunch of them now. That was the first one. And
Yeah.
that's that class of drug that doesn't lead to good, strong bones. So I'm not a fan.
Yes, yes. And over the years, I've heard, I've like, oh gosh, if we all wish that, like, can we just go back in time? But we didn't know what we didn't know. So talk
Yeah.
about the brain fog, because that's a very real thing for women as
Oh,
well.
yeah.
And what the connection is there as, and I think if I'm not mistaken, that's primarily like the decline in estrogen as well. And like what we can do about that is there anything beyond the hormone replenishment that can happen, or is that the main thing that we can do to help with that brain fog that gets all of us in these latter stages?
Yes, exactly. I love this topic because it's really an important symptom. It's really disruptive. We're in our 40s, we're in our 50s, we're kind of in a prime time of our life from a productivity standpoint, career standpoint. So it's very important to address. Lots of contributing factors. Sleep, again, I'm going to keep coming back to that. Really critical. If you aren't sleeping well, then your brain is not going to function optimally. So that's very important. Estrogen, absolutely. That's been shown in many studies. It does settle down after women are completely in menopause, but the question remains, is she at her baseline? I mean, a woman in her 50s is still at an important point in her career. My practice
Yeah.
is mostly online now, but it's also based in person in the San Francisco area, Silicon Valley. So these are, I take care of women who are in the high intensity job situation. Very important that they have that brain sharpness. Estrogen definitely helps with that. Thyroid, very important. Same woman muscling through, wearing out her adrenals, that destabilizes thyroid, which is my theory of why thyroid disorders are 8 times as common in women than they are in men, because we rely on our adrenals. They have this big protective layer called testosterone. Okay, whereas we rely 50% from the ovaries is our testosterone and 50% from adrenals, and then our ovaries go into retirement,
Yeah.
right? So then we're really stressing our adrenals. So that's really important. Also, testosterone, you're giving me a opportunity to shout out to testosterone, which I love for women. A lot of people don't realize that women even have testosterone. Yes, we do. It's very important, has a lot of functions. Again, metabolism, muscle, response to our workouts at the gym, very important. At this point in time, in the United States, we do not have anything pharmaceutical for testosterone for women. We've got bioidentical estrogen and we've got bioidentical progesterone for women, so that's really important. But right now, Canada has a testosterone patch. I believe that England is about, UK is about to have that. We used to have a testosterone pharmaceutical product, but it was combined with oral estrogen, and it's good to avoid oral estrogen anyway. So we have to get that from a compounding pharmacy, and a woman has to be working with a doctor or a nurse practitioner or a naturopath, someone who knows what they're doing and has relationships with compounding pharmacies, so they can be really, they're going to get good quality the vast majority of the time.
Yeah. So you mentioned you don't love the oral estrogen, and you
Yes.
mentioned the compounding pharmacy for testosterone. I know there's so many regulations around testosterone for women, and I guess you can kind of see why, but at the same time, it's like it's a natural hormone in our body.
Yes, yes.
What are you,
It's
go
That's
ahead.
a, no, I was just going to say it's really unfortunate. It's a controlled substance for men as well as for women, which is, I'm with you. It's kind of like, really, people are going to get addicted to feeling good. Okay, sure, fine.
Right.
I guess that's going to
That's
be
the worst
addictive.
thing then. Yeah.
Yeah,
What
yeah.
are your favorite delivery methods for the hormones overall? If you don't love the oral for estrogen, but what are you using with your patients?
That is one of the important lessons from that big Women's Health Initiative study. The women they were given oral estrogen. It was the horse urine
Yes.
Premarin product that they were given in that study. So oral estrogen has what we call the first pass effect through the liver, stimulating the production of clotting factors. And so those women had a small increase in cardiovascular side effects, blood clots, strokes, things we don't want. So with estrogen, that's point number one. The most important feature of estrogen is, if at all possible, to use it through the skin. That can be pharmaceutically available as an estradiol patch. There's an estradiol topical gel. And then, of course, the compounding pharmacies can do lots of different, very detailed, really dial it in for women, different estrogen compounds. I also like pellets. That's another way to do not by mouth. So that's an office procedure, numbing the skin, usually kind of, I'm pointing to the upper glute area. So pellets, that's another route of administration. So as long as we can avoid the occasional woman that she cannot tolerate anything except the estradiol tablet, it's not the end of the world. The absolute risk is still really, really small.
Sure.
So that's very important for everyone to kind of tuck that in their back pocket.
Sure.
For
And are the
progesterone, yeah,
sorry, are the pellets just testosterone, or are there pellets for other hormones
and
also?
estrogen, yes. I
Estrogen.
use them primarily estradiol and testosterone.
Okay.
It gives great levels. I usually don't start women on the pellets because once the pellets are put in, they're really tiny.
Yeah.
You don't feel them once they're there. They do dissolve completely. And I've been doing pellets with patients and also for myself for 9 years of the, let's see, 16 years that I've been in menopause now. So I have a really good handle on it, but it can be a little delicate. So if a woman's just starting on any kind of hormone replenishment, I'll usually start her with something that's easy to stop if she has any issues.
Sure, that makes sense.
Yeah,
And as a
yeah,
woman, yeah, if you don't respond positively, you definitely want to start with
yeah,
something that can be discontinued more quickly. That makes sense.
exactly.
Um,
Exactly.
Go
And
ahead.
then once she's dialed in, the pellets are super convenient. I really like them. They definitely give the best levels. So that's
Do you find once women are through menopause, that their hormones are still kind of fluctuating and you're having to adjust those hormones a lot? Or are you finding that once they're through, they're kind of okay with the certain dosage?
it definitely settles down.
Okay.
The bumpiness of especially going through that stock market phase and then coming out the other side, that's the bumpiest time.
Mhm.
Things do settle down. Half of women will continue to have symptoms, including things like hot flashes and night sweats.
Okay.
So the idea that if a woman toughs it out for a couple of years, like a year or two, and then it'll all go away, that might be true or it might not. My message to women is it's not necessary to suffer.
Mhm.
Using some degree of hormone replenishment to address symptoms does not commit a woman to use hormones forever.
Sure.
Right? Of course, she'll only get the benefits while she's using them, but I always, women think, oh, if I use anything to feel better now, that I'll be stuck, and that's not true.
Okay. But not a lot of predictability to it, does it sound?
Not really. And to your question of do I lower the doses? I would say yes, I do. As everything calms down, we're often able to lower doses. However, I'm keeping an eye on bone density, making sure her other markers are doing well, making sure she's feeling good, and to not be in a hurry to lower things back down. That's important.
Yes. Yes.
Don't, there's no rush. There's no rush. I'm
Yes.
59. I have lowered my estrogen dose a little over the last couple of years, but again, I've been in menopause for a really long time. And I keep a really close eye on it as well.
Sure. So before we close out, I want to make sure I ask, because this is a lot of my practice and what it revolves around, but the stubborn weight gain around the middle, the perimenopause and menopausal belly weight gain. And as we were speaking to cortisol earlier, I think
Yes.
some of that definitely comes into play for a lot of women. But is there anything missing that we haven't talked about already that we can try to avoid that? Or, I've talked to so many women. I'm sure you have too. Every day you probably talk, I
Yep.
didn't do anything different. And here I have 5 pounds of belly, like it's just all in the middle. And I know for me, if I haven't gained 2, 3, 4 pounds, like I notice it right away and it's in the middle. I've been able to curtail that always up until now, but you hear women just like, I cannot get rid of this 5 pounds of belly fat, no matter what I do, and then they start to stress about it, and that's not helpful at all. So is there anything
Right.
we're missing with that piece? Anything that you can add to give women? We talked about how nutrition really does have to change when you're in your 40s and
Yes.
can't eat the
Yes.
same way, and sleep needs to be dialed in, strength training, but anything else that we're missing there?
I do think that, so if I had the answer, I would share it with you and we could both retire the
Yeah,
day before
I'm like,
that.
this is the
Okay.
million-dollar question.
Yeah, for sure, for sure. But I'm definitely, as I said at the beginning, I am addressing this myself as well. You just touched on a few things that are really, really important. And what I was going to say is in the same vein, I am one of these people who grew up, I was doing aerobics in the
Uh,
80s with my leg warmers. I was fully on board with Jane Fonda and that type of exercise. And it turns out that that doesn't do a lot for us
no, it
at
doesn't.
this point in time. And I love my Zumba, but I've actually reduced my Zumba to once a week. And I'm recently starting to introduce more HIIT training, which is really fun, luckily. And I got some bad news recently that even though if I'm using weights to do HIIT training, that's not the same thing as doing the heavier weight lifting workouts. And that does not come naturally to me. I have worked through different times in my life with a trainer. When I turned 50 and I went and climbed Kilimanjaro. Great I worked out with a trainer, getting ready for that. There's times where you gotta have help. But with heavier lifting, that has to be with some type of support for me, for sure. So that's really, really important. And I'm really a student of this, and I'll be saying more about it in my materials as I move forward with my own journey. But there's no question, the deposition of the belly fat, that's insulin, and the changes in the insulin sensitivity. And I was really just rethinking what should I do with some of my dosing. So it really is an ongoing project. It's a joyful project. We don't want to lose the good attitude. Okay. I also feel that there's probably some type of evolutionary protection that they want to, somehow our genes want to make sure that our internal organs are nicely cushioned.
There's some truth to that for sure.
Yes, yes. So we want to balance it. And then there's everything. There's the mental, there's the mindset piece, there's the body acceptance. There's a lot to it. And I personally, I like the hormone balance, the hormone replenishment for women to feel good and be able and motivated to go to the gym and have the energy and stamina to go to the gym. But I think that in addition to breaking up with certain food groups,
Yeah.
as we get
Alcohol.
older.
And alcohol, unfortunately, it just doesn't serve
Yes,
the purpose.
yes.
Yeah.
More grams per gram of a bigger caloric impact than even carbs. So yes,
Yeah.
different
Yeah.
relationship of our body to alcohol. Yeah,
I'm glad you said that because I've never really spoke about it that way. But yeah, I would say the
yeah,
relationship is more critical. And just because it has such negative consequences to our sleep also. But is
right.
there also like there's again, correct me if I'm wrong, a lot of estrogen receptors in the abdominal area as well? Is that kind of why your body's wanting to hang on to some of that abdominal fat? Is there any truth to that? And as the estrogen is falling, that's kind of playing a role too, or not really?
The science needs to catch up. There are different estrogen receptors. There's alpha, there's beta. So, for example, in men, in women, estrogen, at least prior to perimenopause and menopause, causes deposition in places that we're okay with breast development, hips, kind of the feminine body contours. But for men, it does not have that impact. It has that belly. the
Yeah.
estrogen in men can contribute to the belly fat. So there's a lot that people, a lot of smart people are working on the alpha estrogen alpha receptors, beta, which are more going to lead to an increased risk of breast cancer versus a decreased risk of breast cancer. So all of that is important. So I'm not aware that it's different amount of receptors, but the metabolism definitely changes. There are some fancy ways to check this. There's urine analysis of hormones. The Dutch test is a good way to see how is the body processing those hormones. I don't order that all the time because it's not covered on people's insurance. I usually like to, I don't bill insurance, but I like to have people at least be able to do their monitoring using their insurance as much as possible. So there's a lot to it, and we just have to do all the things that we've talked about, that you talk about, keeping a close eye, eating earlier in the day. I've been on a bit of a campaign with women, really this whole thing of fasting. I don't think women should fast for more than 12 hours. That's for most, unless there's like a specific like training for something, like a triathlon or something like that. But for most of us, we need to get up and we need to go with what's happening with cortisol and blood sugar, fuel our bodies as well as our minds, so that
Yeah.
we can
And I have just gone to with somebody who's
also.
really metabolically a mess and there's really no insulin sensitivity. Fasting through dinner can be okay a couple times a week, just to try to restore that insulin sensitivity. But yeah, we,
Awesome. Working with an expert, working with
yeah,
someone who can guide
yeah,
her
yeah.
through those adjustments. That's exactly right.
Yeah, and as I'm sitting here, I didn't even have this question on the radar, but I think I have to ask it. Is there any interplay like GLP-1s are so popular right now? The Ozempic, the Mounjaro, the Jardians. I mean, there's more and more coming out all the time and more people being put on them. Is there any interference between the GLP-1 hormones and the female, like if you're doing the hormone replenishment therapy or anything that we need to be aware of if we're doing both? I mean, the point that people are going to be on them. And I have a lot of people I work with who are on them. And of course, I'm like, well, I'm glad at least you're connected with me so we can dial in the foundations, because chances are you're not going to be on this forever. You're not going to be able to afford it, or the side effects are just going to outweigh the positives at some point. But anything we need to know with those medications and hormone replenishment?
Yeah, that's a great question. You're absolutely right. They're getting really popular, really out there, commonly used. I think that overall they are a good thing. Let me put that out there. It is they're peptides. We hear a lot about peptides to boost growth hormone production and to help with a lot of other cell repair. The way I think, I was taught this early on because I've known about the GLP-1 meds for over a decade, is the GLP, gut, liver, pancreas, in terms of how they work. So they really do help in terms of improving insulin production for those who need that, slowing down the gut motility, which has the upside of feeling full more quickly. Most people eat less when they're using any of these medicines. It's important to avoid constipation. That's really a common and critical side effect because the gut is where hormones are metabolized and disposed of. Okay, so that's really important. It usually, I won't say usually, often, I can say often, somehow in the brain turns off what people refer to as food noise. And then they're just able to stick to the program that they have set out for them. Bottom line is I am definitely a fan when there's some supervision. It can be really tough. You got to be really assertive if you're having any side effects. But I don't think there's any direct competition. Again, the GLP-1s are imitating an enzyme that naturally occurs in the body. And so for people who it helps, then I think that's good. I also like that the dosing can be dialed up, and when someone reaches their goal, the dosing can be dialed back down. So it's a tool. It's a tool in the toolbox.
Yes, yes. And pretty much every practitioner I talk to about this subject, same thing. They're like, I like that we can compound it and we can start with a really low dose and not have to hammer in
Yeah,
that, come in with a sledgehammer with a high dose and people are feeling awful and they can't eat and they're nauseous. But yeah,
yeah,
just dialing in the dose
yeah.
is super
And
important.
another comment from me as a medical doctor out there, the insurance world with medicines is really tough. It's getting tougher and tougher. And so, for example, I've used Ozempic, the actual product, for many years. It was only after one of the Kardashians posted on social media that she was using it and it helped her lose weight, because all those medicines usually help people lose weight. But those are diabetes medicines. And so then it went into being a shortage. And at this point in time, I cannot get it covered if unless someone gets to becoming they get all the way to being diabetic. Their hemoglobin A1C can be zero point 0.1 below the definition of diabetes, they will get rejected
Wow.
for, I know it's really difficult times for that right now. So that's another reason that I like the compounded options
Mhm.
that we have for
Yes.
the right candidate.
Yes, my dad was put on it and I didn't even know he was pre-diabetic. So I don't even know how he got like this all like went under the radar without me knowing. But all of a sudden he's losing all this
Oh,
weight. He's lost like 80 pounds in a year. And I just like 3 months ago, I was told he was on Jardiance. Like I was at one of his medical appointments with him because my mom passed away. I'm like, well, somebody's got to go and listen and know what's going on. And I was like, wait, when did you go on this? No wonder you're not hungry. And so yes, I think that for a lot of people, it can be a very positive thing, but I'm glad that we addressed it and people have,
yeah.
like I just like to ask any expert who works with them just because it is such a hot topic and people want to know. And anytime I put GLP-1 or Ozempic or anything on a post or an email, it's like, whoo, what's the approach
Right.
there? So
Yeah.
yeah, they're definitely
Yeah.
a tool.
If people are already perfect from an insulin standpoint to one of your major areas of focus that you talk about, that's where I don't see it work as well,
Yeah, yeah,
I
that
have to say.
yeah,
So
because
for people who need that,
you're already doing what the medication is there to help with. So
exactly,
your body's already taking
exactly.
that. Okay, well that's all very helpful. So I know you said you have an online practice. Do you work with people like in every state? I know with doctors, like you have to be, certain credentialing in certain states, but who do you work with? And then if you don't work with, if you're overloaded or people are looking for practitioners, a good way to find a good practitioner to help with everything that we talked about today.
Yes, so I'm working on growing my network. I definitely have colleagues in my area, and so my practice, everybody starts out online. We have just a fantastic team that talks with you. Is it a good fit? That type of thing to kind of lead to if they're going to work with me. And in the beginning, including the lab work. So we do a lot of work at the beginning, and that's all online. When people are able to come in person to the San Francisco area for the initial consultation, that is great. I don't require that. I work with people all over the country
Okay.
because it was really the pandemic that pushed me to
Yes.
be
So
able
many.
to,
Yes, yeah.
yeah, yeah. It just pushed me to get a lot of my materials into an online presentation that I when I'm working with somebody brand new, I can recreate just about everything of the experience of being in the office with us. So that's really joyful. I love my day job.
Good. And so it's all 50 states that you're able to work with women?
Mhm. Yeah.
Okay. And men, I shouldn't say just women,
Correct. Yes.
primarily
Yeah.
women. Okay,
Yeah.
tell us a little bit about your Miracle of Menopause network, and then we'll close out.
Wonderful. Yeah, so again, as we've talked about, there's physical challenges that come with these changes, and a lot of focus and attention on that. And sure, that's important. You got to address the things that are not feeling good and what to do about it. And this is a time of life that is a huge opportunity. It's just a complete opportunity, lots of changes for us. Of course, culturally, at this point, a lot of us at this age group, we have kids that are still teenagers around in the picture.
Yeah.
So we've got that combination. But I just really created the Miracle of Menopause online community to highlight that, focus on that. And there's going to be a lot of, it's got monthly trainings. I'm working with a colleague. She's a therapeutic nutritionist, as well as an exercise physiology expert for women in their 40s and 50s. So we're a great team, and we're very excited to bring guest experts as well as all the components of an online program. We're going to have it has all of that involved. But again, it's really the attitude of the opportunity that this time of life presents. We can really, 100 years ago, most women didn't reach age 50, and now half of us or more can expect several more decades. And what do we want to do with that? How do we want to feel? How do we want our lives to be? So that's the purpose and aim of the online community.
Well, wonderful. Well, we'll link all of that in the show notes with your website, how to work with you, and you also have an ebook, correct? That
Yes,
link in the show notes that you are giving
yes,
free. So
as a gift, yes.
we'll link that as well. Tell me the title of it again.
The title of this book, this is the most recent book before the Miracle Menopause book is coming. This is the book prior to that. It's called Go for Great, Dr. Liz's Guide to Thrive at Every Age. It spends more time on a lot of what we talked about. And GREAT is actually an acronym. So the book goes through it's gain knowledge, realize the truth about hormones, explore your expectations, advocate for yourself, and T is for thrive.
Awesome. Well, thank you for that. We'll link that in the show notes. Thank you for today's conversation and sharing everything with us. I feel like we just can't get enough of this information. And the more we can hear it and know it, and going through the experiences, know we're not alone. Every woman who reaches a certain age is going to go through the same thing, not
That's
always
right.
the same way, but it can be a fantastic time of life. So I'm glad we're putting a very positive spin on it. And that you're doing all the work you're doing. So thank you for the conversation today.
My pleasure.